Okay, good afternoon, everybody. Hope you can see us. We are doing a live case from Las Robles Hospital. Can you, put the syringe on? Okay. So before I do anything, I just want to introduce the team. We have Colleen Schall with me, assisting me, Mike Limon, Crystal, on, and on the behind we have Andrew Cannon, who's the cardiac anesthesiologist, as well as the echocardiographer. And you have Pierre and Ali from Abbott, and you have Gabe sitting down there doing nothing. So we have now, it's a very difficult case, and that's why I brought it in. He's an 86-year-old, can you show the next slide? He's an 86-year-old gentleman who was referred to me with a diagnosis of severe MR due to anterior prolapse, and that was the etiology. And I saw him in the office, and he's very short of breath. He's got a problem is he's diabetic, he's got a back problem, he's had a TIA, he's extremely frail, and he also has MR. And based on his just frailty, he's of course super high risk for surgery. His imaging was very challenging. And so what I did is I said, I'll have to do this case anyway. It looked like to be moderate to severe MR by transthoracic. So I put him to sleep, and I'm doing his TE right now. And I'm actually going, I did a transeptal already, but I'm going to show you some of the images. So Andy, why don't you actually just show me as I'm doing the transeptal puncture, I'm just now dilating the sheath, and now you can take it out. And we're going to go with the transeptal, and then I want Andy to show you some of the prolapse and lesions, right? So I want you to now switch to echo. So do this three thing, echo, fluoro, and my hands. Can they switch? Guys, Danny, switch to echo. Echo's not showing up.
Fluoro is working on that. You'll have it shortly.
That's good. Show fluoro on one side. Yeah, keep going. Hey, Greg, how are you? So when you got echo, make echo large and fluoro small. Make echo large. Danny? Make echo large. Make echo large on the right side.
We're getting it right now.
Yeah, that's correct. That's good. All right, so do you want to show?
Working on it.
Good. So I want you to show some of the images baseline. Andy, do you want to talk to the images on the baseline? Actually, just see the guide going in. Sorry. Can you show me the guide going in first? I think it says that. Okay. All right. Let's get this. Go. Why don't we go to some of the baseline images? You show the baseline images while I get everything ready. So, Andy, do you want to speak?
You can. Can you hear me?
Oh, you don't have a microphone on?
I have one on. I just don't know if you can hear me.
Can people hear Dr. Cannon? Because I can't hear you.
Yes, if he speaks loud, we hear him. Yes.
Dr. Cannon, can you speak louder?
Can you hear me now?
No.
Hello?
Does this one work for a microphone?
I don't think the microphone's working. The microphone is not. His microphone's not working.
You want to just talk through it, and I'll.
Okay, so let me just take the guide out. His microphone's not working, Pedro. Can you get a microphone that works for him, please?
How about now?
Can somebody get a microphone that works?
Can you hear me, Sybil?
Okay.
Can you hear me?
I can hear you. Can you hear me?
No.
See, this will last one.
Yeah, we can hear you guys.
Yeah, we
No,
can
you
hear
can.
you now.
No, he can hear us,
How about
me,
now?
but not
Can you guys
go.
hear me?
This Cannon. Can you hear Dr. Cannon?
Can you hear me?
Can you speak?
I'm talking. Can you hear me?
No, I can't hear him. Can you hear Dr. Cannon?
Yes, we hear him, but only when he speaks.
Cannon, speak.
All right, I'm speaking. Can you guys hear me now?
But I should be hearing him, and I can't hear him. No, I
Do you
can't
want
hear
to
him.
just talk through the images then? Is that
Huh?
just easier?
So
You
because
want to
he's
talk through
beside
the
you, you
images?
don't hear him, but we do hear him. Please go on with your
Okay,
case.
say 1, 2, 3.
1, 2, 3.
Can you hear him
1,
clearly?
2, 3. All right, so this is a
Pedro,
long
can you
axis
hear
view.
him?
Yeah, we can hear him.
Okay, good. Can you present? Sure. Show the
Once
images.
again, yes, we can hear him perfectly. Please proceed.
Thank
Okay.
you.
All
This
right,
is a long
present.
axis view of the aortic valve and the mitral valve that we got preoperatively. Just going through it, this is a short axis. Let me get to a couple more. This is our 2 view and X-plane through the bicommissurial view and giving us a long axis view on the right side. This is our 3D view in the en face of the mitral valve. Putting color on it, you can see the jet. We're predicting this to be an A2P2 on the medial side. This is our multi-view view or 3D view. We got a couple different images in order to assess
next
the mitral valve area. We've ranged anywhere between about 5.5 to 7.5. As Dr. Carr said, this is an extremely difficult imaging case, but pulmonary vein showed a blunted pattern.
His airway pressure has changed now. He's got a very prominent V wave. All right, shall we go live now?
Yes.
Let's see the
So now
MR
we're
severity.
live.
Yeah. What's the blood pressure?
It's high right now.
How much?
It's high right now. It's in the 180s.
Okay. And his left atrial pressure, if you can show the LA hemodynamics. Can you show the hemodynamics on the screen? Lot. Can you, yes. And you can see a very prominent, so we did the transeptal puncture already. It was very difficult to do the puncture, so we had a difficulty. We put the guide in, and now we are just advancing the whole catheter into the left atrium. It's a very challenging image to see everything. And I'm pulling the guide back. We're too deep inside, so I'm pulling it right back as much as I can. He's showing me a nice short axis view. You can see the guide inside, and I love that. And I'm just going to do a little bit less to get it in, and I'm just going to advance the guide inside. Very narrow atrium, which makes it harder for us to come out, because if you see so it's sticking into the vein. So let me see if I can now flex it in, because it's going right into the vein. So I'm just going to flex it, and it's going down right now. That looks good. Oh, you move this bad. You saw that, right? It's moved away. Okay, so let's put the guide inside a little bit. And I'm going to go to RAO. Yeah. Okay, just wait. I mean, how much of heparin did we give?
I can hear it.
Give him 2,000 more, it's okay. So I think the guide is down towards the clip to the valve. Can you find it?
Try to find the guide. Sorry. So
It should be seen now better. Go to BICOM. And explain that. Yeah, that's good. So you can see it's a little posteriorly directed. I'm just going to make it anterior. And it's a little bit probably medial. You can advance your probe a tiny bit. If you advance your probe, you'll be able to see it. That's good. That's great. I think we just have to make sure that it looks like we're in good position, right? If you clockwise, counterclockwise your probe, yeah, that's it. See, that's great. So I think you see how it's diving medially? I don't like that. So I'm going to pull back the whole system and take off a little M. Okay, you agree with that? And take a little bit M off. And I'm understraddling it a little bit. And I like that position. So now we are actually well oriented, and I really like the way he's doing the imaging. And so I think, do you agree that this is a nice position? So I'm going to open the clip. It's completely open. As usual, it's rotated wrong. Someday we'll get it right. Okay, let's do 3D end phase. So we want to make sure the orientation on the clip is correct. So we need to turn a little bit more. Take this out. I don't know what to do. Why this happens? It's so annoying.
I don't know either. We do the same thing every time. I don't know why.
No, it was not. It moved a lot. See? But you see, when you rotate so much, you lose. Okay, so I think I'm okay now. Put this in. I like that position. And I like the clip is oriented well with the commissural line. You like the orientation, correct?
Yeah.
Okay, let's go again, yeah. And I'm just going to test the grippers. So that's posterior. You can, the dot is posterior and the blue is anterior, okay? So, no, I'm just going to get it better. And I like that. We need to do more posterior. So one of the things I may lose height. And even though let me see if I get height. I think it's still okay. See, now it's really nice, right? And let's put color there. I like that position. What do you think? We can go a tiny bit more medial. I think we should try to get as medial as possible. Do you decrease the tidal volume?
Okay.
So we'd like to decrease the tidal volume because that prevents the clip. See, that's a very nice picture. You see how he showed that it's in the middle of the pizza. And I think, Andy, I like that, right?
Yeah, looks good.
So I'm actually going to go in like this. So I'm going to close the clip. And I'm going to slowly advance the thing into the ventricle as he's keeping it. He's doing a great job in this imaging, which is actually extremely challenging. And now I'm going to open the clip. And you can see the microflail there, right? It really looks good. Yeah. So what we should do is bring it back and do a 3D. Can we do a 3D? Can somebody be with, yeah, Pierre is there. Good. So I think you can see the anterior flail now beautifully. And you can see that the orientation is a little bit off. And I think I should counterclockwise it a little bit. You agree with it? Decrease the gain?
A little bit.
Yes, see that. I like that. I might actually turn out a little bit, take off a little bit of M. I like that position. How do you like that? The orientation? Tell him that.
Pop the whole image just like now.
I think this is good. I actually like this really nice. And I think the orientation is very good, right?
Looks good.
All right, so I think the position is good, right? Question is, should we move it, bring it a little more
Color.
Going to color, yes. We can come back a little bit more medial if you want. Okay, so let's go to that BICOM LVOT view. He's on the money there, it seems like. You want to put color there? Yeah, I think it's in a nice position. So I would like to play with this color off. And I'm trying to be as medial as possible. And you can see how the anterior leaflet is falling nicely into it. I'm just worried about the anterior leaflet, the posterior leaflet. See that we got a nice insertion of the.
Interesting.
Okay, and I'm going to drop each of the grippers. And actually, I want to make it a little negative. Yeah. 3D end face. Decrease the gain. It's difficult to see the clip, right? I can't see the orientation.
Gain a little bit.
Oh, you see? Oh, yeah, that's great. So you see it moved. So we should take it off, right?
You got a counter.
Yeah. And I don't like this as usual.
Let me get a better view for you.
A little bit of M. That's a bit too much, right? That's good, right? Like that. Now let's come back and explain. I'm just wondering whether we should have used an XT, yeah? I think we lost the orientation. Can we go back and see the orientation? Or for some reason,
Go back on them.
Yeah, let's just optimize the BICOM a little.
Okay. Let me get it back.
yep.
It was 70, was it?
I don't think
They put the line through it.
Wherever you had it.
3D end face that. It's in a good location. Okay, that's actually, the orientation is perfect, right? I just have to be underneath the anterior, right? Okay, so let's keep the orientation correct and let's try to move more anterior. Okay. Let's go back to Bitecom LBOT. That looks nice. And then I'm just going to open up the clip a little bit so the leaflets can fall. I think both the leaflets are on, right?
Mm-hmm.
I don't know whether the leaflets have got it. I don't see the gripper, right?
You want to assess posterior?
No, I actually want to see the orientation. Leaflets are really nice. See the orientation, please?
You want 3D on plus?
Yes, that's great. So the orientation is lovely, right? This is exactly where we want it, right? There's a jet again medial to that. So this is why we want to. Okay, let's just, shall we just close it on this one and see what happens?
Sure.
I don't think we got the anterior. See that, guys?
We lost it.
Okay, so let's open the clip. I think we got posterior, okay? I think posterior is in. So the dot is posterior, so let's pull the blue
Correct.
back. Let's move it in. Okay, got that. Yep, now it's moving.
Mm-hmm.
I think we should check. I don't think we need to check. Lock it, good. I like this better.
You want 3D here?
Right? So we got a very nice anterior insertion. We also got a reasonable posterior insertion. Okay. And let's look at color now. Oh, that looks really nice. I think we've done a reasonably good result, right? So let's, what do you think, Andy?
Yeah, I think so.
So we'd like to show you what we did. First of all, let's focus on leaflet insertion. I think we have enough posterior and we definitely have enough anterior, correct? We also see that the jet has reduced a lot and there's only one jet on the lateral side. The LA pressure is 6 with a prominent A wave, no V wave. You can show him the V waves, okay? And we should look at 3D
Okay.
and see what it looks like. And we're on the very medial side of A2P2. And that's exactly where we want it. And you can see how beautiful that there's no color jet medial to the clip. Medial is on this side, right? And there's a lateral jet small far away, but there's a nice tissue bridge.
Yeah, it looks really good.
So you're Colin, that's the mitral valve, Colin.
No gradient.
Colin, you're an embarrassment for us. So now we could get, I think let's do one more color assessment and a leaflet insertion. And I would say we can do it at 0 degree if you want, or is he doing gradients? So we have this method. We do leaflet insertion first, then we see color flow, then we look at the gradients, and then we do 3D and the pulmonary veins. So let's look at this one. He's showing it nicely. He's bringing the probe down. Advance your probe a tiny bit, and you see a very good anterior insertion of the leaflet.
You want to get color here?
And you can do color now. And there's no jet. And there used to be a big vertical jet going laterally, right? So we can do another view for the leaflet insertion, right? So I would just use BICOM, and because I think this view is not the best. Let's do a pulmonary vein, of course. I think you got the right upper, right? And the gradient. We may be done in this case.
Double
We-
check.
Yeah. So it's important to do every step. Yeah. So he's looking at the right pulmonary vein. It's all red, which is a good sign, right? Which means the flow is. So that's our normal systolic flow. Okay. So that's great. Was actually more. It wasn't very blunted before. Is that what you got before too?
Yeah, I was blunted
Okay.
before.
What's his blood pressure now?
158 over 78.
150.
158 over 78.
So that's very good. That's her blood pressure is 150, 170 with a LA pressure of 6. So that's a really good sign. And do you want to do BICOM LVOT? And let's look at leaflet insertion properly. Okay. I think that's the only thing we have to do. That's a
Just gonna
nice
get a
BICOM.
Quick gradient.
What's happening? Gradient? We're checking.
You want a
No, let's
gradient?
look at leaflets. So I like the anterior for sure. Right?
A lot of movement, but I think it's a long way.
Yeah. And I also like posterior too. No, anterior I got very well because I remember I did independent grasping. And I think the posterior is nice too. Right. Okay. Good. I'm going to do, we've done a 3D color, so let's do a gradient. You want to do a deep transgastric
Probably
to really?
check posterior a little better.
Huh?
You should probably check posterior a little better.
Okay.
You want to check posterior?
Sure. Then we have to explain that.
Gradient.
So the MitraClip, there's a lot of thinking that we do. So the gradient is nothing. You can see that. And you see this, it's a big A wave and no V wave. So the MR is gone almost.
Straight solid.
Yep, that's it. Two, okay, great. So the gradient is nothing with a heart rate of 80 and a blood pressure of that. So that's actually a very good sign. And we just,
Posterior again?
yeah, so he just wants to see posterior insertion. So I would go explain.
Explain.
That's good
Let
posterior.
me just sweep through for you. It's medial. Here's at the clip. And here's lateral.
And then you want to put color to see color flow on either side.
Sure. So once again, medial. Moving towards the clip.
The tiny horizontal jet left still.
And here's lateral to the clip.
Yeah. Okay. Good.
Back to
I,
the clip.
I'm not actually am, but I prefer not to open it because it's everything else is looking good. But if you want, I can just do it a little 60 and see.
Yeah,
what
we
it-
could always open a 60 Sybil. Mm-hmm.
It's up and over. See that, guys? I think it's up and over. I mean, if you want me, then I'll have to. I mean, I don't want to lose anterior. The dot is posterior, right?
That is posterior.
Um,
You want single plane?
no, stay like that. Let's zoom it for me. I actually would take this. I mean, I can do clockwise, yank it up. Okay. You see how it's bouncing around? So
Yeah.
the dot.
Mm-hmm. I agree.
I'm not going to play around with it. I actually like it very much. Hope I didn't lose anterior. Posterior is definitely in. I like that. Okay. There's no jet MR. I really would leave this. I'm happy to deploy this, guys. Is that okay? Right?
You got way more posterior. Are you guys comfortable with posterior now?
Yep. It was in there.
Okay, good. So, Colin, you want to do it? So first, close it up tight.
Okay.
Okay, good. Now,
I'm gonna copy neutral.
yeah, tighten it up again a little bit for me.
Want me to go
No,
neutral?
tighten it up.
Tighten it.
I like to
Tight.
tighten it, clip nicer. The leaf to say in.
Okay.
Now try to open it.
Copy
Good.
neutral.
Good. Great.
There's neutral.
Good.
Positive side.
Yep.
Okay.
Then this one.
On the closed side?
Huh?
I mean,
You're on the closed side of neutral?
Yes,
Yeah.
we are. Okay, good. So now we're trying to grippers. I really think that the credit for this case goes to Dr. Cannon, who gets such beautiful images in a very challenging image thing. We actually didn't show you that the initial transeptal puncture was very difficult to do because of the shadowing in the right side. But we want to show you that the key in this procedure, pull this other one. No, pull this.
yeah, I'm doing this one next.
No, don't
I
touch
have to,
the-
no, I've got this.
Okay, good.
Yeah,
Now floss it.
flossing.
Good. Okay. The key in this procedure is to have very good imaging. And I think we work with cardiac anesthesia and they put the patients to sleep. They can control the tidal volume and get the circuit. So try to open it, the clip. No, actually, I like to,
Sloppy, right? You like to
close it completely.
Okay.
And now make neutral. Just neutral.
Okay.
Good.
Okay, neutral.
Good. Now take this
Then-
off. Yep. And then
Open
5 times.
until I see the.
So
red.
this is going to allow me to this. Yes.
Where is it?
Good. And
Do you
8
see it?
times.
Oh,
Yes.
there it is.
That's it. That's enough.
Okay.
1,
1,
2,
2, 3, 4,
5, 6, 7, 8, and then gently pull back. Pull that back. Good. And now the clip is deployed, very steady. And we see a beautiful deployment. There's no change in air pressure, which is good. And there's only just mild medial jet. So this looks very nice. So while you're getting, huh? Yeah. And I'm actually now going to slowly take the M off as I'm trying to.
To the right here.
Can you see how much of guide we have?
Short axis.
Just short axis the guide. We always want to make sure the guide is in. Inside, you're ready to go. Open this up. Okay, that's good. Now you can interrogate the mitral valve. Okay, aspirate. So this was a nice placement of the medial part of A2P2. In a very challenging case, we used a smaller clip. But when we do this, before we take the guide out, we want to check everything. So let's do a study. First of all, what is the blood pressure?
146 over 76.
So the blood pressure is 146 by 70, which means that's good. That's what he is. And we're trying to assess the MR at this blood pressure. So he's first doing a nice 3D picture. And he's going to rotate it around. So we're doing a 3D end face. We see the clip is very well inserted. Yeah. There was look at that beautiful picture, the aorta on the top, the appendage on the left side, and you can see a nice tissue bridge between the medial part of A2P2. And if you can decrease, yeah, and decrease the gain a little bit to make it more clear, the image.
Let me get one more view.
Okay.
Let me get it perfect.
Yeah, why don't, yes. Get a cleaner image if you can.
Yeah. Give me 1 second.
That's it. Peter, help him out. Okay, that's great. You can hold the tidal volume if you let. Okay, good. That's great. More atrium. You should do. That's nice.
That looks really good.
Yeah, you should do more atrium so you get less ventricle. All right. And clockwise it to show me the medial orifice is very small, and there is. Let's put some color there now.
That's the whole image.
Yeah. So there's nothing. You see, there's a tiny medial jet. There's a tiny lateral jet. It's actually gone. That's very nice. The gradient was only 2, right?
Yes.
And that's so now I think we got the pulmonary veins, and I think we're done. While I start taking out the guide, you agree that we're not going to put another guide catheter inside, so I'm going to pull the guide out. Take the final LA pressure, please. It's key to assess the MR in normal blood pressure. So I'm over this. I'm going to, do we need to do another ACT? You did one moment ago? Okay, good. Measure this final LA pressure. This is with the guide out. And then we're pulling the pigtail out and we measure the LA pressure. Just want to close the groin. Yeah, his RA pressure is high actually. We probably should have done the right heart study to see what the pressures are in his lungs. He may be having underlying lung disease also. But at least we fixed his mitral valve very nicely. We've just a single perclose in the vein, and we'll do a figure of 8 stitch. We'll put a figure of 8 stitch in the groin now. Can we get a figure of 8 stitch?
Bad TR?
There's your right to left side.
Yeah, it's very small actually. Pedro, show the groin,
Not
and we're going to do a figure of 8.
Mm.
That was actually a nice case. In 40 minutes, we got a single clip in an anatomy which is very challenging, especially a large aorta, a very small right atrium.
Very posterior.
Did we see the final color? So I'm doing a figure of 8 stitch in the groin, in addition to 1 perclose. I find this very useful to actually stop hemostasis, and usually I keep it overnight, and then I take this figure of 8 out in the morning. And usually that's enough, because otherwise sometimes with just a single perclose, I don't like to use 2 percloses in the vein because sometimes it causes stenosis. I don't like that. So I usually put 1 perclose and a figure of 8 stitch. And this is a fisherman's knot that I'm just doing in the groin.
Not the best.
He's 86, very, very frail,
Maybe the best I can
wheelchair
get.
bound, and this is such a safe procedure. His blood pressure didn't drop through the entire procedure. And now you can see that there's no bleeding in the groin at all. We put 1 stitch in the groin.
Yeah, I know. I'm just saying that's the view I'm going to get.
In the last pictures, I'd like to show you if he's trying to look at the tricuspid valve and seeing if there's what the peer pressure could be like. The aortic valve is normal. We should look for pericardial effusion, even though the blood pressure is normal and should be okay. Kathy from Long Beach just walked in.
That's all I'm going to get. I can't with this patient.
So, I think if there's no other questions, Andy, is there anything else you would like to show us?
No, that's it.
You want to show us a deep transgastric? Is that what you're showing us?
Yeah, I was just going to do a transgastric now.
Yeah, that'll be nice. We usually don't use this view anymore because we use 3D end face view, but he's trying to show you the possible a deep transgastric view on the echo. Can you pull it back a little bit, the probe? And that's actually quite nice. No, not yet. Don't show his body. Okay. Yes, I think that's nice. And put the color on there. You can see how medial we did a clip. and you can put the color jet there, and you can see there's absolutely no TR, MR, and that's actually just that's artifact. There's really no MR at all, and you see how medial we were, which is where we saw the jet, correct? And and these are quite difficult sometimes to position the clip medially, and you see the lateral orifice is very big. So I actually want to, in the meantime, take the opportunity to thank everybody. Mike just scrubbed out. Mike, thank you very much. Ali from Abbott, thank you very much. Colleen Shell, that's the mitral valve Colleen, by the way. I also want to thank Kathy from Long Beach, who's come here to work today. Thanks for coming in. So, arigato gozaimasu. And Andrew Cannon, outstanding cardiac anesthesiologist and imager. And you can see how relaxed he is. He's doing anesthesia, he's behind the patient, doing imaging. And this is something I'd like to teach a lot of people, that I think most MitraClips can be done with a cardiac anesthesiologist and them imaging the patient and putting the patient to sleep. And Pierre, thank you. Pierre was there. We always make sure that the Abbott rep is always there. Or any of the clinical specialists are very important in these complicated procedures. And no matter how experienced you are, you should always listen to them, because they always have, so they see things which sometimes you don't see. So with that, actually, I want to thank everybody. And I want to thank Samin Sharma and Samir Mehta for allowing us to present this case. And Gabe Areta is falling asleep over there, but now he's awake. Thank you.
Thank you.